Okay. Hello everyone. Welcome to Unacademy. Let's crack NEET PG. Okay. So I'm Dr. Shilpa Dinesh. I'm a practicing pediatric consultant in Bangalore. I have an experience of teaching undergraduate and postgraduate medical students. I have done my MBBS and MD from Rajiv Gandhi University of Health Sciences. Okay. So today we'll be discussing about malnutrition. This is continuation of yesterday's topic. So yesterday I had discussed about the introduction to nutrition. So today the abnormalities in of nutrition will be discussing. So today we'll be discussing malnutrition. We'll be discussing severe acute malnutrition, kwashiorkor, and marasmus. Okay, and the management. Okay. So before we move on to the discussion, I would want to talk a little bit about Unacademy. Unacademy is India's largest online learning platform, and if you subscribe to the subscription, you have daily live classes. You can chat with your educator, engage with discussion, ask your doubts. Your doubts will be answered immediately, okay, in the live chat box. And these live classes you can attend every day with your favorite educator. And to prepare for any exam preparation, you need to have a structured course. Okay, so in Unacademy, all the courses are structured in line with your exam syllabus, and it will be a great help, and it will be also a big boost for your preparation. Also, whenever you're preparing for your entrance exams, you need to evaluate yourself. You need to know what are your strong areas, what are your weak areas. How do you evaluate yourself? With live tests and quizzes. In Unacademy, you have regular live tests, quizzes, mock tests, and this will help you analyze yourself, analyze your performance, and then you can concentrate on your weaker areas. Okay, also the unlimited access. So once you subscribe to the subscription, you can get access to all the live classes. Even if you had not attended, you can go back, you can attend, I mean watch the live classes even later, and all the recorded classes in the subscription. Okay, so all this at the comfort of your home and with your own device. I would highly recommend this platform, and using this platform in the early part of your preparation would be of great help, and it will take a long way. Okay, these are our top educators. They have daily classes on this platform. Kindly go check their classes. Okay, yeah, and all the 19 subjects are taught here, and you can revise through all these topics anytime. And these are the ongoing courses in our platform right now. And coming to the subscription, so we have the package ranging from 1 month to 24 months. I would suggest you either the 12-month or the 24 months package, because as you know, this NEET PG is a preparation which it takes a year-long preparation, and a 12-month or a 2-year subscription would be very good, and it is more reasonable. So it is, the 1-year subscription is 25,000, and if you use my code Shilpa10, you get a 10% discount, and it will come up to 22,500. A 2-year subscription costs you around 30,000, and using my code Shilpa10 gives you a 10% discount, and it will cost you 27,000. Okay, so I would highly recommend it, and the prices are very reasonable compared to other platforms, so give a try. So now, talking about malnutrition. So malnutrition, uh, both undernutrition and obesity comes under malnutrition, so comes in the spectrum. So if if undernutrition, if undernutrition is one end of the spectrum, then obesity is another. So both are malnutrition. So you have to be the optimal nutrition, I mean balanced. Being balanced is the best, is the optimum way to live. Okay, So first, before we go further, let us know what are the classifications under undernutrition. So there are three indexes, parameters or ratios, okay, in which we classify undernutrition. First being weight for age. Second is the height for age. Third is the weight for height. Okay, so weight for age, generally it only tells you about the undernutrition and it can't tell you more. So if it is very low, though you the weight falls in the third, I mean in grade 3 or in the severe weight loss category, you can't, I mean, you cannot comment much on the acute or the chronic malnutrition. While height for age, the child presents with stunting and it represents chronic malnutrition. Okay, the weight for height is reduced, it can be acute or acute and chronic malnutrition. Okay, so there are various classifications. So the first classification over here, uh, I have taken is the Gomez classification for underweight. Okay, the index used here is weight for age. Okay, so any child presenting with edema, even if the child is grade 1 or grade 2, under Gomez's classification, it is taken as grade 3. Okay, so if the weight for age is between 75 to 90%, it's grade 1 of PEM or malnutrition, then 60 to 75% is grade 2, less than 60% is grade 3. Okay, so above 90% is normal. Fine. Next is the jellyfish classification. Okay, so jellyfish classification has 4 grades. Okay, so again, weight for age of 80 to 90% is grade 1, and between 70 to 80% is grade 2, and 60 to 70% is grade 3, and less than 60% is grade 4. Okay, so jellyfish starts from 80 to 90%, while this starts from 75 to 90%. 90% has always been the. The next is the Wellcome Trust classification. Again, the index over here is weight for age. Now, in Wellcome Trust, they've divided into 60 to 80% and less than 60%. Now, 60 to 80%, if associated with edema, is kwashiorkor. Okay, if 60 to 80% there is no edema, it is just underweight. And if it is less than 60%, then it is severe, and if it is not associated with edema, it is marasmus. If it is less than 60% with the edema, then it is marasmic kwashiorkor. So marasmus is severe. Okay, got it. So if a child, in according to Wellcome Trust classification, if the child comes with 60 to 80% of weight for age, then it is kwashiorkor. If associated with edema, without edema, it is only underweight. It is less than 60% without edema, it is marasmus, and if it's less than 60% with edema, is marasmic kwashiorkor. Okay, next is Waterloo's classification. Now the index is height for age. So Waterloo's index classification for stunting. So Waterloo's classification is for stunting as well as wasting. So when height for age is used, it is for stunting. So if the height for age is between 90 to 95%, it is grade 1. 85 to 90% it's grade 2, and if it's less than 85%, it is grade 3. While McLaren's classification for stunting, if it is 80 to 93%, they call the child short. But if it is less than 80%, the child is called as a dwarf. Okay. in WHO classification. So this is important. WHO classification, if the height for age is less than -2 standard deviation but more than -3 standard deviation, okay, it is moderate. But if the height for age is less than -3 standard deviation, it is severe. So this is one of the criteria for severe acute malnutrition. Okay, the WHO classification with less than -3 standard deviation is severe malnutrition. Okay, yeah. And another thing is height for age measures the linear growth. Okay, next, coming to the next classification. Again, I've told you, Waterloo and McLaurin's classification is there for both wasting and stunting. So what you need to know is, stunting is height for age, while wasting, the index which is used is weight for height. Okay, yeah. So the first classification where we use weight for height is the Waterloo's classification, which indicates wasting. If the weight for height is between 80 to 90%, then it is grade 1 of wasting. If it is between 70 to 80%, then it is grade 2 of wasting. And if it's less than 70%, it is grade 3 of wasting. Next one being the McLaren McLaren's classification for wasting. Again, weight for height is the index used here. If it is between 85 to 90%, it's mild wasting. 75 to 85%, it's moderate wasting. And if it is less than 75%, it is severe wasting. Okay, yeah. Again, coming to WHO classification. So as you can see, the height for age and weight for height, they have similar names for classification. Same, basically same name for classification. But only difference is height for age indicates stunting. If there is decrease in height for age, it indicates stunting. If the weight for height is decreased, it indicates wasting. Okay. Now, WHO classification, where the weight for height is less than -2 standard deviation to more than -3 standard deviation, this moderate wasting. If it is less than -3 standard deviation, which is severe, and it is severe wasting. Okay, yeah. Now coming on to marasmus. So marasmus is a severe form of wasting. Okay, so I will show you the pictures of marasmus in the quiz when I take MCQs on malnutrition. That time I will be showing you pictures on marasmus, right? Okay, okay. Severe form of wasting. Okay, the word marasmus is derived from the Greek word marasmos. Marasmos. Okay, that means wasting. The Greek word. Marasmus is a Greek word, remember. Okay, how do you grade marasmus? So, grade 1, when there is wasting in the axilla and the groin, it is grade 1. Okay, when there is wasting in the thighs and buttocks, it is grade 2. So, that time there is this baggy pants appearance. Okay, grade 3 is the chest and the abdomen. Next is the buccal pad of fat. So once there is wasting in the face also, when the buccal pad of fat is also lost, that time the child will have this monkey faces. Okay, so buccal pad of fat is the last to go. I mean, last to go in marasmus is because it is metabolically least active. And the brown fat, which is one of the first to lose, first to go in a child with marasmus, because it is highly active, highly metabolically active. And you, as you all know, brown fat is important for thermogenesis. right? Okay, so these children are active, they have voracious appetite, but in the later stages, they can become irritable. Okay, so this is for marasmus. So these are the main points, and this classification you need to know. Okay, so from the so first is the axilla. So first is the axilla, then the thighs and the buttocks, then the chest and the abdomen, and then the face. Okay, coming to kwashiorkor. So kwashiorkor was first recognized by Professor Cecily Williams in 1933. Okay, in the Gold Coast. So what she noticed is, so when a child was born, I mean, when a second child was born, the first child was ignored, because the second child, basically the second child would need a lot of attention, so the first child wouldn't get the same attention as before. And in these children, they noticed there was malnutrition. Okay, so that is why this word is referred from the Ga language of Ghana, which means KWASHIORKAR, which implies pretend not to mind to the korkor, that is the second child. So this is also called as the disease of the first child. Okay, next. So this grading of kwashiorkor is also very important. Okay, so as I've told you in the last class, so whenever community pediatrics is involved, it's a very important topic for your NEET entrance preparation. So all these are, they might look simple, but they will be given importance in your exams. Okay, so the child comes with grade 1 pedal edema. So pedal edema is the first thing you have to see. Okay, so how do you check for the pedal edema? You have to pull the child's leg and press over the ankle, just above the ankle, both the sides, for 10 seconds firmly, not very hard, firmly press. And then if there is pitting edema, that is called pedal edema. Okay, so what is grade 2 of kwashiorkor? There is grade 1, that is pedal edema plus facial edema. So there is pedal edema and facial edema. So this facial edema will give you a, I mean, the child might be actually under, I mean, has undernutrition, but this facial edema gives a wrong picture, thinking that the child is all right, baby is plumpy, but no, facial edema is a sign of kwashiorkor. Okay, next. So grade 3 involves grade 2, that is pedal edema, facial edema, and paraspinal and the chest edema. Okay, so grade 4 involves pedal edema, facial edema, paraspinal and chest edema, and includes ascites. Okay, yeah. So it starts with pedal edema, then it starts with pedal edema, then goes to facial edema, then goes to paraspinal and chest edema, and then there will be ascites. Okay, so what is a triad of kwashiorkor? So triad of kwashiorkor is, there is growth retardation, there is mental changes. These will be very lethargic, apathic, mental changes, and there will be edema. Edema is like the very important feature in kwashiorkor. Okay, what are the other features? Now, as I've said, there is facial edema. It gives a sugar baby appearance. Okay, uh, then there is flaky, sorry, yeah, then there is this flaky paint appearance. So flaky paint appearances, there will be desquamation and pigmentation of the skin. Okay, and then there is this peeling of the skin, which gives this flaky paint appearance of the skin. Okay, next is the mucous membrane. Mucous membrane, there is glossitis, cheilitis in children with kwashiorkor. And in the hair, there is this flag sign. What is flag sign? Flag sign is there is an alternate band of hyperpigmented and normal color hair. Okay, that is called flag sign. Okay, coming to severe acute malnutrition. So when do you say it's severe acute malnutrition? So this is very important. Yeah. So any one of the three following three criteria is enough to tell it is severe acute malnutrition. Okay. When the weight for height, so this is important. Weight for height is less than -3 standard deviation on the WHO growth chart. So it's a WHO growth chart, we need to remember. So weight for height is less than -3 standard deviation on the WHO growth chart. So weight for height indicates what? Weight for height indicates wasting, thinning. Okay. Next, or or presence of bipedal edema. If the child just has bipedal edema and not necessarily should have -3 standard deviation of weight for height in the WHO group, bipedal edema is also enough. Or if the mid-arm circumference is less than 11.5 centimeters, 11.5 centimeters. Okay. Next, how do you manage? Okay, so now a child, this is a management for severe malnutrition. Okay, so this management in severe malnutrition is divided into stabilization and then divided into rehabilitation. So stabilization can go up to 1 to 7 days, and rehabilitation can go up to 2 to 6 weeks. Okay, so hypoglycemia. So if so these children, since yeah, these children have a high chance of going into hypoglycemia. As see, what happens is, when there is decreased nutrition in the body, there is other physiological mechanisms in the body trying to uh, conserve energy. So the liver will not be producing glucose, and as a result, these children will have hypoglycemia. So any blood sugar, blood glucose level of less than 54 milligram per deciliter should be managed. Okay. Oh, and uh, so if the child is asymptomatic, you should just give oral 50 ml of 10% dextrose orally in asymptomatic child. But if the child is symptomatic, so symptomatic can be anything. So symptomatic child can be lethargic, there can be seizures, okay, no, non-responsive. So that time you have to give 5 ml per kg of 10% dextrose. Okay, this is followed by 50 ml of 10% dextrose in the nasogastric tube. Okay, and this child should be after this the child should be started on F75 every 2 hours round the clock. Okay, and antibiotics also should be started. So remember, this a child with hypoglycemia is someone who has less than 54 milligram per deciliter of GRBS, or the random blood sugar. Okay, so this child, if the child is asymptomatic, you give 50 ml of 10% dextrose in the nasogastric tube. Okay, if the or orally, depending if the child can take it, can take it orally. If the child is symptomatic, first give a 5 ml per kg of 10% dextrose, and then uh, 50 ml of 10% dextrose in the nasogastric tube, followed by a F75 every 2 hours. Okay, hypothermia. So as I've told, the body tries to conserve. So even here, the brown fat will not go for thermogenesis. This, as much as possible, they conserve. So that is why these children are more prone for hypothermia. So if the rectal temperature is less than 35.5 degree Fahrenheit or less than 95.5 degree Fahrenheit, then you should consider it as hypothermia, and that time you should check the sugars also. Now, so how do you manage? Cover the child with warm clothes. Okay, you should put the child in a, I mean, warm with on a heat in a heat on a, near a heater. Skin to skin contact should be given so that the temperature improves, but a rapid rewarming should not be done, slowly. Okay, and the child should be fed. Feed the child, and antibiotics should be given. So antibiotics and all should be given so that secondary infections don't happen. So even hypoglycemia, hypothermia can. Okay, so next, dehydration. If the child has dehydration, this is a very bad sign. Okay, dehydration is very bad, so you have to see that you give ORS. So ORS should be given orally if the child can take it orally, and then you can start with F75. So electrolytes, on day 1 itself, magnesium sulfate should be given. That's 50% magnesium sulfate should be given at 0.3 ml per kg. Okay, so that is 50% MgSO4. So 1 ml will have 4 milliequivalents. Okay, so 0.3 ml per kg should be given IM. Next, so infection should be avoided in these children. So antibiotics should be added. Micronutrients, a mega dose of vitamin A should be given. So if the child is less, I mean, if the child is more than 1 year, you give 2 lakhs of vitamin, 2 lakh unit of vitamin A, and if the child is less than 1 year, then you give 1 lakh units of vitamin A. Then folic acid also should be supplemented. Folic acid, zinc, copper, and iron. So folic acid is 1 mg per day, and zinc is 2 mg per kg per day. Copper is 0.2 to 0.3 mg per day, and iron is 3 mg per kg per day. Okay, these are for micronutrients. Initiate feeding. So the child should be started on F75. Okay, and then slowly you can go to F100. Okay, this can be prepared. Catch up growth. The child should be monitored for catch up growth. So when the child is removed from all the adverse effect, I mean adverse environment, that is the child was not receiving proper nutrition. So once the child is stabilized, initiating feeding and giving the right calories, good amount of nutrition, the child will have a catch up growth. Okay. Next, sensory stimulation. This is by play, having a cheerful environment. So this is very important. So for an overall development of a child, having a very good sensory environment around, having a happy environment, having a happy childhood is very important for the overall growth of the child. Okay, so prepare for follow-up. So So primary failure to respond is failure to. So now the child has gone home. So what do you have to see? So failure to regain appetite by day 4. Failure to lose edema by day 4. So this is very important. So keep all this in mind. Failure to lose edema by day 4. So presence of edema on day 10. Even, okay, day 10. Failure to gain weight. Gain weight of 5 gram per kg per day on day 10. So this is called primary failure to response. So what is secondary failure to response? So that is failure to gain weight of 5 gram per kg per day on consecutive days when you're on the rehabilitation phase. So this child in the stabilization phase has been gaining weight, maybe, but then when the child is in the rehabilitation phase, baby is not able to gain weight. So that is called secondary failure to response. Okay. So now once the child has gone home, once child has been discharged, what do you do? Okay. So once the child has been discharged, you have to see that the child receives at least 175 kilocals per kg per day. Okay. This is very important. So every day, child should receive 175 kilocals per kg per day to maintain the weight gain. Okay, and uh, and if any in these you should give a course of antibiotic. Amoxicillin is given. So also regular follow with the healthcare worker. So healthcare worker comes home and monitors the child regularly. Okay? And again, sensory stimulation is a must. So a playful, happy environment is needed for the overall growth of the child. Okay, yeah. So before we finish, we will discuss again, like in a fast. So as I said, malnutrition is not just undernutrition, it can be undernutrition as well as obesity. So this is the spectrum. So you being in the center and having a balanced weight is a must. Okay, so to know under to define undernutrition, there are three parameters what we use. One is weight for age. One is weight for age. Next is the height for age. Third is the weight for height. So height, height for age measures the linear growth, and if it is decreased, that means there is stunting. While weight for height, if it is decreased, it indicates wasting. Okay, okay, indicates wasting. So under weight for age, there are three classifications. So There is Gomez classification, Jellyface classification, and Wellcome Trust classification. Okay, so these all the three use weight for age as the parameter to uh, classify underweight. Okay, so uh, yeah, in Wellcome Trust classification, a weight for age between 60 to 80% and less than 60% is taken. This is with or without edema. So 60 to 80% with edema is called kwashiorkor, without edema is underweight. So less than 60% with edema is marasmic kwashiorkor, without edema is marasmus. Okay. Yeah. Again, for the next classification is using height for age. So in height for age, we use Waterloo's classification, Maclaren's classification, and WHO classification. So this class name of the classification is same even for weight for height. Okay, so in Waterloo's classification, which indicates stunting, the height for age is between 90 to 95%, 85 to 90%, and less than 85%. It grades up to grade 1, 2, and 3. Maclaren's classification, height for age between 80 to 93 is called as short, and if it's less than 80%, it's called as a child is called as a dwarf. If the WHO classification, the height for age is less than -2 standard deviation to more than -3 standard deviation is called moderate stunting, while height for age less than -3 standard deviation is severe stunting. Okay, next is the parameter is weight for height. As I've told you, the name of the classification is same as height for age. There is Waterloo's classification, Maclaren's classification, WHO classification. Okay, so this WHO classification is the main this less than -3 standard deviation is one of the criteria for exam. Okay, so marasmus. So marasmus is a severe form of wasting. As I've told you, it is derived from a Greek word called marasmos. Marasmos. Okay. The grading of marasmus is divided into 4 grades. First, the axilla is involved, then the thighs and buttocks, giving it a baggy pants appearance. Then the chest and the abdomen is involved. Then the buccal pad of fat is involved. So buccal pad of fat, when it is lost, it gives a monkey faces. Okay, so as I said, buccal pad of fat is the metabolically least active. That is why it is the last pad of fat to be lost. Okay, these children have a voracious appetite and they get irritable in the later stages of the malnutrition. So while kwashiorkor was first noticed by Professor Cecily William in 1993 in the Gold Coast. Okay, so this is derived from the Ga language of Ghana. Ga language, Ga language of Ghana, which means Kwaniyoshi Korkor. That means pretend not to mind the Korkor. That is, Korkor means the second one. Okay, and this is also called as a disease of the first child. So as I've told you, when Professor Cecily William saw that when the second child was born, the first child was ignored, and as a result, this first child wouldn't be given, would go into malnutrition. So so that is why this is called as a disease of the first child. So how do you grade kwashiorkor? So again, grading is 4 grades are there. So first starts with pedal edema, then the facial edema. So pedal edema and facial edema is grade 2. Pedal edema, facial edema, and paraspinal and chest edema is grade 3. Pedal edema, facial edema, paraspinal and chest edema with ascites is grade 4. Okay, yeah. So this is again very important. So there is a trial for kwashiorkor. So growth retardation. See, these are questions you should not get wrong if it comes in your so there are bounces. So bounces will be there in all preparation, all entrance exams. But these are the repeats or the same questions, and these you need to know. You cannot be going wrong in these questions. Okay. So growth retardation, edema, and mental change. So this is a triad for kwashiorkor. So other features of kwashiorkor is sugar baby. As I said, these children have facial edema, and we tend to take it wrong, thinking the baby is plumpy, chubby. There can't be malnutrition, but that is the appearance they have, sugar baby appearance. And flaky paint appearance of the skin. There is disformation, peeling of the skin, or pigmentation of the skin. So that gives a flaky paint. So when you would have seen, when there is moisture on the over the paint, then paint flakes off. So such kind of an appearance on the skin you can see. Then the mucous membrane lesions are glossitis, cheilitis. Okay. And the hair shows flag sign appearance. So flag sign appearance is there is an alternating band of hypopigmented and the normal hair. So that gives a flag sign appearance. Okay. So severe acute malnutrition, what did I say? When the weight for height is less than -3 standard deviation on the WHO growth chart. So out of these three, any one criteria, if any one criteria is there also, is enough to be termed as severe acute malnutrition. So one is weight for height of less than -3 standard deviation on the WHO growth chart, or the bipedal edema, or the mid-arm circumference of less than 11.5 centimeters. Okay, so these again are, these are all simple but very, very, very important questions. Okay, next. So there are 10 steps in the management of severe acute malnutrition. So first of all, the management is divided into stabilization phase and rehabilitation phase. Stabilization phase is divided into 1 to 7 days, and other is, rehabilitation phase is divided into 2 to 6 weeks. Okay, so first you have to stabilize. So hypoglycemia, hypothermia, dehydration, electrolyte, they all come in the stabilization phase. So if the child comes with the blood sugar levels of less than 54, that means you have to take it as hypoglycemia. And if the child is asymptomatic, so even though the child has less than 54 sugars of less than 54 milligrams, but the child is asymptomatic, baby is not lethargic, active, then what you should do, you have to give 50 ml of 10% dextrose through the nasogastric tube. But if the child is symptomatic, the child is lethargic or there's seizures, first you give 5 ml per kg of 10% dextrose, followed by 50 ml of 10% dextrose, then followed by F75 every 2 hours. Okay, the child should receive F75 every 2 hours throughout the day. Okay. Next, hypothermia. So if a rectal temperature of less than 35.5 or 95.5 Fahrenheit, 35.5 degrees Celsius or 95.5 degree Fahrenheit is considered as hypothermia. You should always take GRBs when the child has hypothermia also. Warm the clothes. You should keep the child close to a heater. You should give skin to skin contact. Feed the child. Also start on antibiotics. So even when the child has hypoglycemia, you have to start on antibiotics. So when there is dehydration, give ORS. If the child is lethargic, you can give ORS through NG. If the child is able to take orally, give through orally, and then the child should be given an F75. So F75 basically 100 grams of F75 gives you 75 kilocalories. If it is F100, it gives you 100 kilocalories. Okay, so electrolytes on day 1, magnesium MgSO4, magnesium sulfate, 50% and magnesium sulfate is given at 0.3 ml per kg. Okay, it's given IM. So 1 ml has 4 milli equivalents. Next, infections should be controlled with antibiotics. So these children are highly prone to have infections, okay, because the immunity is lowered. So antibiotics should be added. Micronutrients, vitamin A, a mega dose of vitamin A is given. So if the child is more than 1 year, you give 2 lakh unit, and if it is child is less than 1 year, you give 1 lakh unit. And other micronutrients what I use is folic acid, you give 1 mg per day, zinc 2 mg per kg per day, copper you give 0.3 to 0.2 to 0.3 mg per day, iron you give 3 mg per kg per day. Okay, and initiate feeding, you start with F75. As the child tolerates, you can go for F100. So catch up growth, basically when the child is removed from all these adverse environment, child generally catches up growth and will be equivalent to a child his age. So generally if this if the child has lost so much weight for a very long, there has been stunting for a very long period, then to reach the peers is a little is very little less. But yes, catch up growth still happens, but to reach the peers sometimes it might not happen, because time a lot of time is lost to reach that height. Okay. Sensory stimulation, as I've said, a happy, playful, cheerful environment is required for the overall development of a child. And preparing for follow-up. So how to know if it's a primary failure to respond? So if there is failure to regain appetite by day 4, failure to lose edema by day 4, if there is edema on day 10, if there is failure to gain weight, even 5 gram per kg per day on day 10. Okay. What is secondary failure to respond? If there is failure to gain weight of 5 gram per kg per day on rehabilitation phase, so that, okay, is called secondary failure to respond. So I'm hoping you'll have understood today's topic really well. So this is a very basic topic, and as I've said, the gradings of kwashiorkor, gradings of marasmus, triad of kwashiorkor, classification of severe acute malnutrition, management of severe acute malnutrition. So any of these can come in your NEET PG exams. Okay, so these are very basic questions, and not answering these questions is a sin, I would say. You have to be answering them, and I hope you've understood it very well. And tomorrow I'll be talking about micronutrients, and micronutrients and their deficiencies, like vitamin A, all the deficiencies. So we'll see you tomorrow. And yeah, use my code Shilpa10 if you're subscribing to the subscription, and you can get a 10% discount. Okay. Yeah, see you tomorrow then.